Now we have the next presenter, Dr. Afirima, under the topic, Delivering HIV Treatment Services for Key Population, the Nigeria Experience.
Good morning, ladies and gentlemen. Good morning, good afternoon, good evening from whatever part of the world you are. My name is Dr. Barinaadaa Afirima. I want to take you through the Nigerian experience in delivering HIV services for key population. As an introduction, globally, HIV is a leading public health threat of the 21st century. As of 2020, an estimated 79.3 million people have been infected with HIV since the start of the epidemic. You know, we're in the fourth decade of the HIV epidemic or pandemic. Over the last 4 decades, we've had about 79.3 million people infected with HIV. So 2020, people living with HIV as of 2020, you have about 37 million people estimated to be living with HIV and AIDS. Among these, you have 1.7 million children within the age of 0 to 14 that are living with HIV as of 2020, based on the UNAIDS estimate. And 58% of all people living with HIV were identified as women and girls. Interesting to note that we've lost about 36.3 million people have died from AIDS-related illnesses since the beginning of the epidemic. However, sub-Saharan Africa, where I practice, where Nigeria is located, during the ep 20, about 75% of the total number of people living with HIV reside in sub-Saharan Africa. And Nigeria has the largest population the second largest population of people living with HIV in the world, with about 1.8 million people affected in 2020. It should tell you the burden and the gravity of HIV in sub-Saharan Africa, and Nigeria in specific. However, certain population, access to treatment and care is not evenly distributed. Equity is not evenly distributed. Available data shows that key population bears disproportionate burden of the HIV epidemic. However, this population that has a disproportionate burden of the epidemic have limited access to healthcare services. In 2020, globally, it was recorded that 65% of new HIV infection occurs among key population and their sexual partners. Okay, who do we define as key population? Key population includes sex workers, male or female, men who have sex with men, gay men, people who inject drugs, and transgender people, including people with closed setting. Now, what is the burden of this within this population? The risks of acquiring HIV in this population compared to the general population. When we mean general population, people, every other person apart from this key population. Now, among key population, you'll find out that among people that inject drugs, compare them to general population, they have 35 times higher risks of acquiring HIV compared to the general population. Among transgender women, you have 34 times, transgender women have 34 times risks of acquiring HIV compared to the general population. Sex workers have about 26 times. And while gay men and men who have sex with men have about 25 times risks of acquiring HIV compared to the general population. It's to tell you that the burden of the infection as per risks of infection is among this population. Now, going down to Nigeria, there are no estimates right now, but it's estimated that about available data, the data for size estimate is very limited in Nigeria as possible. Available data program estimated that about 1% of the Nigerian population are key population. So just 1% of the population of Nigeria are key population. And it's estimated that 37% of all new infection in Nigeria is among this population. Regrettably, the Nigerian society is a conservative society. The Nigerian law criminalizes men having sex with men and female sex work. Therefore, most of the members of the key population mainly remain underground. They don't disclose their identity. Because of decriminalization and stigmatization associated with this, key population face unprecedented level of stigma and discrimination in the society. As I told you before, from available data, globally, they are the epicenter of the epidemic. So what's the problem? The problem is that the traditional health system are not keep-up friendly. If they are the epicenter of the epidemic, that means we got to facilitate them. So we got to increase access and uptake of services for this population. However, the traditional health system are not keep-up friendly. Because they're not keep-up friendly, a key population face high level of stigma and discrimination within the health sector. And as a result of this, there is poor uptake of HIV services by key population using the current service delivery model. So the problem is poor uptake of services by key population. Why? Because of high level of stigma and discrimination that is perpetrated with the current model of service delivery. I want to give you an overview of the current model of HIV programming in Nigeria. HIV program in Nigeria is mainly donor-driven. The two main donors are PEPFAR and the Global Fund in collaboration with the government of Nigeria. Government plays its role because government staff support the process. But when it comes to critical funding, it's basically donor-driven, and then you have some level of private sector involvement, the Bill and Melinda Gates and the Clinton Health Foundation. However, the health service system in Nigeria is predominantly public health and private health facility driven. And this model of services, these systems and this environment are not key population friendly. HIV programming in Nigeria is basically implemented through local organizations and international organizations that collaborate with health facility to deliver services. So most of the donor funding goes through international organization or local organization, and these organizations implement through the health system, existing health system. Now, this slide showing you the service delivery model. Basically has then primarily the public and the private health facility constitute the main service delivery model. What have we done now? How are we evolving this system based on the differentiated model approach to ensure that there's equity and equity of uptake of services among key population? We've introduced the mobile AI refill and the community center. So I'm going to dwell more about the community center has an effective way to optimize access to treatment HIV services among key population. However, I just want to give you a rundown of the public and the private health sector. Most referrals are made from IPs who have mandate to diagnose key population. There are implementing partners. IPs are implementing partners that have a mandate to optimize increased access to care and treatment among key population. Because as we've alluded to earlier, that key population remain the epicenter of the epidemic. And if we are to eliminate HIV and AIDS as a public health threat, we must address issues around uptake of services among this key population. Now, the healthcare facilities, healthcare workers in these facilities are trained. However, their curriculum, most of their training are not initially key population oriented. Now, services are referred to these health facilities, but what are the shortcomings in this health facility, the traditional health facility? The traditional health facilities have large clientele, but because of government regulation, because of traditional prejudice, because of societal prejudice and religious bias, key population cannot identify themselves based on their gender identity and sexual orientation. The current Nigeria database and documentation system acknowledge only two sex, male and female. It's just binary. It does not acknowledge other minority sexual orientation and gender. So the current, so that is translated in the public health facility. So in the public health facility, the documentation, the national documents, the biodata of the national document and fair document only acknowledges male and sex. So this discriminates against key population. They cannot come down and identify themselves. As we know, key population are highly mobile population. Sex workers are mobile because of their trade. Men that have sex with men, sometimes they're underground. Other members of the population are highly mobile. And referral and tracking becomes a great challenge because the current traditional health facility was not designed to attend to mobile population, but was basically designed for static population. In the current database, in the normal routine traditional health facility system, HIV services are not disaggregated based on just male and female. Sex, other sexual identities are not recognized, are not identified. So it's difficult to get data from that. Now, with an evolving system, the communities, the ALT refill came on board, whereby clients could, because of the differentiated approach of service delivery, you have services developed to the community, whereby you have the ALT refill, people are having access to treatment in the community and in community pharmacy. That has been optimized in Nigeria. However, for the purposes of this presentation, our focus is the community center, which involved the drop-in center. It was initially set up, basically community centers in Nigeria are in the form of drop-in centers for key population. These are buildings or private or location, which are located in areas whereby key population feel safe. The drop-in center are safe spaces that provide HIV and other health services in a KP-friendly manner. This space also serves as a safe space for key population because of issues around law enforcement, stigma and discrimination, and gender-based violence. Now, so locating a drop-in center is a very sensitive thing, whereby we got to look at areas that we know that are not conspicuous because of issues around stigmatization. We got to look at where we think is safe for the key population community, where we think they can access services unharassed, unmolested. So as citing the drop-in center is a critical step in optimizing community centers. So you got to look at location, you got to ensure that it's not branded because of issues around social, stigma, law enforcement, and others. What are the steps in citing this drop-in center? We're going to do a stakeholder mapping and engagement with relevant, this stakeholder mapping and engagement includes sensitization of relevant government agencies, implementing partners and network of people that live with, living with HIV and the key population community. We got to identify existing resources. Are there locations in the community that we think that it looks safe, that could tolerate citing such in that community? Then we got to identify the HRO, the human resource that will support this site. Now, as I told you before, that the current curriculum, most of the curriculums, training curriculums are not very robust when it comes to key population training and orientation. So we got to identify staff, clinicians, expert client pharmacists, and other community level workers that we could actually build their capacity on delivering a key population oriented services. we use the national curriculum on a general basis, and then we adapt the training to the national curriculum, but ensure that we highlight issues around delivering services in a key population-friendly environment. And then we activate the drop-in center, we set up services, and then we provide ongoing technical assistance to that drop-in center. Now, the reason is that the traditional drop-in center is not like your private health facility. It's not like your public health facility. It is a safe space, so the environment must speak of safety. Then the staff personnel working there must not display any level of stigma or discrimination towards their clients, and it must be in a safe location. So we provide ongoing technical assistance to ensure that the level of services meets the minimal requirement in the public health sector. Then the next thing is, how do we manage commodity inflow? As I told you before, we had to seek buy-in from relevant government agency. So we use the Unified Logistic Management System that is supported by PEFA and Global Fund in collaboration with governments of Nigeria and its relevant agency. We did not set up a parallel system because we're looking at sustainability at the end of the day. So commodity flows from the Unified Logistics System to the community center and to the health facility, and we triangulate that with the community, the ALT refill at the community. So you find out that there is a communication between the health community center and the health facility. We operate a hub and spoke method so that there's an interface between the health facility, both public and private health facility, and the community center for ease of reference and supportive supervision and capacity building. Now, the preliminary data when we operated within a space of 6 months is that we have 149 new patients were identified, came to services, tested, and linked to treatment. But we have 149 persons initiated on treatment. Three of our clients came from the public health facility through referral and joined us. So they were not original clients we tested into services as at then. Now, out of the 149, based on WHO standard, the gold standard of monitoring patients living with HIV is to do a viral load at 6 months after they've been on treatment for 6 months. So out of the 149, 36 of them that were on treatment were eligible for viral load. 34 out of the 36 of these, which is over 90% of the samples were collected. Out of the 34 viral load tests that were done, 24 of these were viral suppressed, which is about 70% of viral suppression. The goal of HIV treatment, antiretroviral drug, is to ensure that a client has an undetectable viral load. That will enhance quality life of that client. So out of the 34 of the clients whose samples were collected for viral load, 24 of them had undetectable viral load, which was good based on our standard, based on contextual realities in that environment. Now, what have we learned from this in conclusion? What have we learned from this? That increasing uptake of HIV services among key population will require a model of service delivery and not the one-size-fits-all that is a traditional health facility, public and private. And the differentiated service delivery must be anchored on a stigma-free environment. Stigma and discrimination has been one of the reasons why key populations do not access services. So two basic things is that a differentiated model of service delivery is the best way if we're going to optimize treatment for HIV services for key population. And this must be anchored in a stigma-free environment. Apart from HIV treatment, antiretroviral drug, what are the next steps of things we need to do? We want to strengthen pre-exposure prophylaxis, uptake of pre-exposure prophylaxis among key population, and improve case detection, HIV case finding and case detection among key population using the sexual network testing. Thank you very much.
Thank you so much, Dr. Afirima. I will request the participants to post queries in the QA session or in the chat box so that Dr. Afirima would answer. We have a comment for you, Dr. Afirima.
Okay.
A very informative presentation, and the presenters were sharing their valuable knowledge and research ideas. That was a wonderful presentation.
Thank you.
We are receiving a lot of appreciation for your work, for your presentation.
Okay, thank you. Thank you, everybody.
We have one question from a participant. How respective are faith-based organizations in accepting and managing HIV in key POPs?
That is very interesting. We are on a journey. As I told you before, our society is conservative and a very religious society. It's evolving, although there is still significant bias in population, population activity, but it's work in progress. We still have a lot of work to do.
We have one more question. What measures has the government put in place to ensure that these key groups access HIV services?
Okay, basically through strategic advocacy with relevant agency, we are beginning to see buy-in from these agencies. So when we go for supportive supervisions, we have representatives from these government agencies that support that process. As I did inform you that the law do not support the legal system, the legal framework is not KP friendly, but our entry point is from a public health approach. So we are beginning to see using data for decision making to drive the epicenter of the epidemic. Now, because Nigeria is, there's a global quest to eliminate HIV as a public health threat by 2020, and that will not be possible if this is not addressed. So we're getting buy-in from strategic partners using high-level advocacy from government agency. So the first thing is that they are participating in trainings and orientations. They are participating in supportive supervision. So we strongly believe that this will have a ripple effect on the whole system.
Thank you so much for that brief. We have one more question. Given the illegal context of key populations activities, do you think reducing waiting time in health facilities can help ameliorate HIV service uptake among KPs?
That is very correct, reducing waiting time. But the issue of waiting time is when somebody comes to the facility. If people are not coming to facility, there won't be any issue. Now, what we are saying is the key populations are not coming to health facilities. It's not about waiting time now. For the general population, waiting time is a problem. But for members of key population, the traditional environment is discriminatory. So they rather depend on their peers for treatment. So they don't come to health facility and they are not identified as key population. But I strongly believe with you that waiting time issues is something we could actually do to optimize uptake of services for a general population services. But right now we're trying to drive demand for services by key population. And the drop-in center seems to, and the community center seems to be a game changer for us. And we strongly believe that when we now begin to have high volumes, we will now begin to look at issues around waiting time. We now begin to optimize issues around multi-month drug dispensing. Precisely.
Thank you so much, Doctor. That was a wonderful presentation, and I hope like all the participants would have benefited. Thank you so much, Doctor.
you.